The dose you're supposed to be on is no withdrawals, no cravings. I'm going to add something to this. It's maintenance. Maintenance means a steady state throughout the day. Hey everybody, welcome back to the channel. It's been a little bit. My name is Dr. B, Dr. B Addiction Recovery, and let's get started. The question or the topic I will dissect today in some detail is what is the right dose of Suboxone and why you need to know the answer to this question in a formal kind of a deep dive way so you get it right. So let's go ahead and get started. On the outer layer, the most basic thing that I really mean by this is what is the dose, the right dose? Is it 2 milligrams, 6 milligrams, 8 milligrams, 16 milligrams, 24 milligrams? What is the frequency of that dosing? Once a day, twice a day, 3 times a day, once every other day, once a week, whenever you want to take it, which is typically called PRN as needed, and that's how a doctor would order it. And finally, one that is a topic of extensive misunderstanding and some controversy is how long do I need to be on it? And why is this important? Why am I even covering this? Because you would think that, hey, I go to the doctor, why is it even a question? Well, you would think that I go to the doctor and I need to be on blood pressure medication or I need to be on blood thinner medication. The doctor makes some sort of an assessment and looks at certain parameters, what your blood pressure is, what your age is, what your other factors are that will contribute to the success of this medication, and pick one of 2, 3, 4, 5 doses, or maybe it's just a single dose that is written on the label of the medication. And this doesn't seem to be the case with Suboxone. Let's review some basic things by Suboxone. Number one, what I mean by Suboxone is any buprenorphine product. What is buprenorphine? Again, I've covered a lot of this extensively in other videos. Basically, it's an opiate agonist antagonist medication. To really understand what that means, maybe you can go to some of my other earlier videos that describes that, but essentially it is a type of opiate medication. Now, why is this even a question? Should we not know the answer? Well, apparently, I can tell you this. There are some of the answers that we do know, and some answers we formally don't know. And thirdly, everyone seems to have gotten it wrong. I'm not going to review the issue of naloxone in the Suboxone, and Suboxone is a brand name which has buprenorphine and naloxone. I'm just going to kind of assume that we're only strictly discussing the buprenorphine, which is the generic name for the main active ingredient of this drug that does its trick. 2, I am going to strictly discuss, actually 3, using this product not necessarily for pain, but this is for the opiate abuse client coming my way. So if you come to me and you say, hey doc, I have an addiction to heroin, fentanyl, prescription opiates, that's who we are talking about. They may have other issues, real chronic pain, anxiety, depression, and so forth, but that is the classic client or patient I am addressing here. So let's get moving on this. The right dose, and let me just give you the answer right off the bat. The right dose that somebody needs to be on with this medication and how a doctor is supposed to assess that dose is within the range of prescribing, which is whatever, 0 to 32 milligrams, and I'll tell you why 32 milligrams in a minute. Within that range, and sometimes you can go over that range, even though that is what the manufacturer has as the theoretical limit where all of your receptors are filled. Within that range, the dose you are supposed to have a patient on maintenance medication, maintenance dosing for medication-assisted treatment has to cover 2 grounds. No withdrawals, no craving. Okay? No withdrawals, no craving. There's not much other parameters that you can measure except knowing that the patient is both reporting to you, and some of the withdrawals going to be obvious, right? But you should be well past somebody sweating, being anxious, having body aches. But the dose you're supposed to be on is no withdrawals, no cravings. I'm going to add something to this, over a 24-hour period, 7 days a week. Okay? What does that really mean, right? That means, A, you certainly should not take it as needed. Oh, I take it as soon as I start to feel this, or I take it every other day. Okay? So that's out when we're talking about a chronic addict that needs to be on maintenance medication. It's maintenance. Maintenance means a steady state throughout the day, 24 hours a day, 7 days a week. So there has to be a regularity to it, okay? Whether it's once a day, twice a day, 3 times a day, whatever. That's number one. Number two, everybody's gunning for, I'm going to try to take the lowest dose possible for as short a time possible, okay? That's wrong. The dose you're supposed to be on is no cravings, no withdrawals. Okay. Now, I know this is going to create a lot of feedback, negative feedback, and everyone talking about Suboxone is the worst thing to be on. I don't want to trade one addiction for another. For the most part, I'm not addressing some of these issues in this video, although I've addressed them many other places. I want to get down to business, what you're supposed to do. You're supposed to be on a dose, whatever that dose is, between 0 and 32 milligrams, sometimes a little bit more, or in a 24-hour period, you have no psychological or physiological withdrawals or cravings. Now let's talk about numbers. What is that number? Well, we know from international data that most people fall somewhere between 16 to 24 milligrams. Some higher, some quite a bit higher, not quite a bit, but maybe even 40 milligrams, but that's very few. And many, many much lower. But that's not what you should be thinking about if you're serious about long-term recovery and the hope of ever getting off of opiates. 16 to 24 milligrams. That dose should really be adjusted within the first week of coming into contact with the provider. At that time, hopefully the provider really educates you and changes your mindset about the dose you're on, the fact that it's okay to validate any fears you have, any inhibitions you have, any stigma you have, because you have to understand, okay? You're not walking off the street and getting yourself on an opiate. You already have a pretty severe addiction to opiates, okay? And at this time, we are trying to mitigate, minimize, and in general, reduce all of the consequences of that addiction to your body, to your mind, and to your immediate social culture that you are embedded in. And that is the only way to start thinking about long-term recovery. If you take care of all of that stuff first, forget about the medication. The second question that I think falls within the concept, the idea, or the question is of the dose is, how long do I need to be on that dose? And this is a little tricky and a little not. And I share this very openly with patients, is that I don't have that answer at this time. And there's no formal science or data that can give you that answer. We just don't have it. It's possible that I can get you off in a couple of years. It's possible that I might get you off in 5 or 6 years. But with the addition, with the caveat, positive caveat that, hey, you're at 32 milligrams now, but in 4 years, in 3 years, in 2 years, you might be at 8 milligrams maintenance. And it's also possible that you may have to be on this for the rest of your life. And this is for some folks, it's a difficult pill to swallow, and it's up to the practitioner to package this in a way that they can actually take this in, digest it, and be okay with it. Okay. And to understand that, look, we are talking about, it's not Suboxone or the heroin or the oxys that is bad. It's the addiction to that drug, to that substance, and all of the impact that it has on your physical health, on your mental health, on your emotional health, and on your social evolution as a sentient, aware, and cognitively functional human being that wants to live and get some pleasure out of this life. So at this point, we make choices about benefit and risk. What is the best thing I can do given the circumstances? And once you really get them to digest and accept that idea, you can proceed. Some notes on when is a good time to get off of Suboxone, okay? And many relapses occur because of the surrounding circumstances of getting off of Suboxone, and many complaints come back off of the circumstances surrounding getting off Suboxone. Globally, most people get off of it too early. In addition, their taper is too fast with too large a numbers of taper. And every single one of those points is a negative that sets you up for potential relapse. Okay. A lot of the issues surrounding every one of those concepts that I have discussed here have been discussed in a lot of my videos on opiates and Suboxone. It really covers the whole thing, so I'm not going to go over all of it. I can only say this, that there still seems to be this very strong stigma. There's strong drive from individuals, families, society, culture, the system that is to get you on this and off of this as fast as possible. And that's not what this is. Accept it as a medication for a chronic, relapsing, remitting issue that you can achieve long term recovery or sobriety. And the key here is do it correctly, do it right, find a correct practitioner. A couple of other little notes I'll add on top of this is this: taken at the right dose, in the right hands of the right practitioner, this stuff will deal with a lot of anxiety issues, a lot of insomnia issues, a lot of depression issues, and a lot of pain issues, correct? Right? And so this is why it's so critical you find a practitioner that can manage this thing to make it really dance for you in the best way possible, to minimize your overall medications, to maximize your emotional health, your psychological health, your cognitive engagement in the world, and your sleep, obviously. That is what Suboxone can do. By the way, when I say that anxiety and depression, there's plenty of data that buprenorphine products can work great for treatment-resistant depression. I certainly won't have someone with treatment-resistant depression at this point in time in the world and say, hey, try Suboxone. But most of these patients all have severe anxiety, severe depression, severe sleep issues from years and years of kind of traumatic exposure, socially, psychologically, physically, and so on. And this stuff, done in the right way, can really make it so you're on a minimal amount of medication and being optimal in your long-term recovery. If you like this stuff, or even if you don't like it, but you find it interesting, useful, controversial, please subscribe, press the like button, and consider joining us as a patron on Patreon for as little as $3 a month. We can go a long ways with as many subscribers as I have. Hopefully I have more videos coming for you soon. Thank you very much. Stay safe out there. Recover. Peace.